Next talk is by Professor Jeewan Titiyal
Yeah,
on simplifying surgical techniques in smile.
yeah,
Thank you, Namrata, and I'd like to wish Airways uh, success on this particular venture of something different, where we have people from the across the world sharing their knowledge to our members. I think we had a great beginning of this session where rightly pointed out the therapeutic use of, for example, laser. Looking to refractive surgery, I consider it's not only cosmetic surgery. It has a lot of therapeutic aspects also when we're treating patient with a refractive error, maybe a mild, moderate to severe refractive also. And looking into the history of refractive surgeries, you know that since the beginning of refractive surgery, when lasers came up, till date, all the procedures, right from the surface ablation to examine laser, are still in practice. That means whatever surgical aspect we consider with laser surgeries, they still work very, very fine. I think since FDA approval of 2016, the small incision lenticle extraction, the entire armamentarium of refractive surgery laser base has changed, mainly because SMILE has advantage of lesser ocular surface disturbance, less dry eyes, and more importantly, it has a greater biomechanical stability than the flap-based surgeries, which may be an important decision-making point for a patient undergoing laser refractive procedure. If you see this confocal microscopy of one of our patients, comparing SMILE versus the femtosecond laser, this is pre of subbasal nerve plexus. And if you see after 6 months of surgery, SMILE has a definitely better looking nerve plexus, which directly implicates that patient would have less damage to the subbasal nerve plexus, which has a very significant relationship with the outcome subsequently in a laser refractive procedures. Apart from that, it gives a better ocular surface. More importantly, better stability of cornea in terms of biomechanical strength. Maybe that might lead less regression, less dry eyes, less inflammation, and better outcome for a long-term future also. I'm not going to go in the hardware and software of a SMILE system by Visumex. We know that surgery is important aspect for all of us. We need to learn that, and it does have a learning curve. A few important aspects is that docking, femtosecond application to create the refractive stromal lenticule. Then manually we have to extract this refractive lenticule after opening the cap, then delineating the anterior and posterior plane of dissection, complete dissection of lenticule, and taking out this entire procedure. This was our review article in the clinical ophthalmology regarding the various techniques people use for extraction of lenticule and dissection. People have various techniques, but it's always better to have something which gives a right orientation. If you see this diagrammatic representation, first we normally like to go anterior plane dissection. That means separating the lenticule anterior surface from the cap, and subsequently go posteriorly so that you have a two plane of dissection and you can remove easily. Difficulty arises when we don't actually appreciate the two plane dissection, and which can give so much of a surgical difficulties and some complications subsequently. Just to show a representative video here, you can see this is a centration based on a pupil centration. This is a creation of an intrastromal lenticule from periphery to center, then the side cut. Then we'll have a creation of a lenticule cap, which comes from a center to periphery. The one that is completed, the last one is a incision or a side cut here, which is normally 2 millimeter. So if you see here, you have a two clear circles. This is a lenticule side cut, and this is a cap. Once we understand, then dissection becomes simpler. So if you massage out the opaque bubble, you can see the clarity of incision, and you can nicely open that and dissect the first anterior lamellar pocket, which is normally in the 2 millimeter, we open entirely. If you have a larger incision, which is 3 to 4 millimeter, people do it left side first for anterior, and as you saw here, then do a right side for the posterior. So this is what clearly indicates the a little bit of a frill, which is, suggests that we have disturbed the lenticule edge. So I'm doing an anterior plane dissection that is separating the lenticule from the cap, and it has to be done in a very smooth manner. So once we have a nice OVL formation, application of laser correctly, the dissection is very light and very simple, and it takes very less time with experience to dissect out. Normally, I do a quadratic dissection so that flap doesn't flap into one side, which makes things difficult sometimes. So once you have complete dissection for all around, now you can see almost 360 dissection has been done with the spatula. You can use other devices also. Spatula gives a better movement, and you can in fact take out the entire lenticule without using a forceps. Use of forceps now with experience having almost less than 1%. That also decreases the forceps related complications. So this is our initial paper on a learning curve, where we realize you do have a various challenges during the learning curve. But as you cross 50 eyes, the difficulties decrease from 60 to 2%, which is a significant decrease in all cases. So one of the most important things which normally we tell people is to correctly identify the anterior pocket and posterior pocket, either right or left side. And in this way, meniscus sign, which we described, gives a very nice appreciation of a two plane dissections and helps you to identify that you have definitely dissected both the sides here or a posterior side at least. Accordingly, when you dissect out, if you are anteriorly, the clear line is behind the spatula. If you are posteriorly, you can see the entire edge is anterior to the spatula in these cases. If you have difficult dissection, you create a lot of difficulties or complications, and things can go wrong. This is one of my first challenging case of cap lenticular adhesion. You can see I'm doing an anterior dissection first to the pocket, but subsequently I'll dissect out the entire plane. In this case, you can see I'm doing a dissection, which you saw in the initial case. Now I'm struggling to find the posterior plane. So this is what happens normally. This can happen. You can see when I was doing an initial dissection, that time only I had gone posteriorly. If you see the initial frill, it gives you an indication you have gone posterior to the anterior plane. So this is a technique where you have to nudge out the flap edge, then go anterior to that and dissect out, and you can finish the surgery as effectively as routine case in such case. If you see, this is another case now where we normally now, rather going anteriorly, sometimes I go posterior dissection first also. That can also be done very effectively. So identify, lift the edge, then dissect out the entire area. So once you have a complete dissection done, like you see here, I'll go take the entire spatula, dissect out the anterior plane, which normally we do it. Here I'm doing a posterior plane dissection first. So once I take out the entire dissection here, you can see this visible ring is also indicate that you are directly posterior. In that situation, what I'll do, I'll just nudge out this frill with the same spatula, push it out, push it towards the central area, so you are now anterior. This flaps gives you appearance of a bow type of pattern. You go anteriorly, then your dissection becomes very simple. In fact, if you dissect posteriorly first, your surgery can become simpler and faster sometimes also. So this is after 7 days of picture, which gives you indication that dissections simpler, lesser granules are seen in these cases. If you are doing a Rexis type of procedure, then you have to do 2 areas of meniscus where you can peel from either side, and things can be easier also. Cap tear and sidecut extension are very, very rare nowadays, but that can happen in the beginning, and that normally doesn't cause significant change also. Even for our cases where you require retreatment, which is going to be covered subsequently, you have a nice algorithm now, and all cases can be treated very effectively for retreatment also. So things have become simpler for us. Despite having learning curve, if you can really identify the 2 plane of dissection by various techniques, which Dr. Mahipal also going to talk about, then things become simpler. If you have a difficult dissection, you can compound your surgical problems. But despite the surgical problem, the outcome in a smile is quite effective, and patients have a very satisfactory results. Wet lab training may help, but it's always better to see the other surgeon doing surgery or see videos and look into the appropriate steps of your surgery to improve your results. Or you can go through various books. These are 2 books on refractive surgery available through JP Brothers. People can go through them with the videos also. thank you for your kind listening. And again, thank you, Dr. Namrata and AIOC, for holding this meeting and giving this opportunity.